Drugs for treating digestive disorders. At the end of this, students should be able to summarize common symptoms related to common gastrointestinal tract conditions and disorders, recognize warning symptoms of severe GI conditions, identify examples, therapeutic uses, and clinical concerns for drug classes commonly used to treat GI conditions. Provide patient instructions for taking medications for GI conditions that are administered orally or rectally as an enema or suppository, and describe the mechanisms of action for common gastric acid reducing medications. The gastrointestinal tract is an organ system responsible for nutrient absorption, waste excretion, and immunity. The primary organs of the digestive system include the following: the upper GI tract, including the oral cavity, esophagus, stomach, and duodenum; the lower GI tract, including the small intestine, the cecum, the colon, the rectum, and the anus; and the associated glandular organs, including the gallbladder, pancreas, and liver. Gastrointestinal complaints that is often inconsequential. In patients with minor complaints, a medical history and physical examination are all that are required. Acute and severe abdominal pain, however, is almost always a symptom of an intra-abdominal condition that may be emergent. The patient may be referred for a medical exam swiftly. Some emergency conditions may include shock, peritonitis, and cholecystitis. In cases of appendicitis, the gold standard is an appendectomy, where we remove the appendix. However, in some cases, a non-surgical approach with treatment with antibiotics might be viable. There are far fewer complications to not have surgery, so it is ideal in some patient populations. Nausea and vomiting. Nausea, the unpleasant feeling of needing to vomit, represents awareness of the afferent stimuli to the vomiting center of the brain. Vomiting is the forceful explosion of gastric contents caused by the involuntary contraction of the abdominal musculature when the gastric fundus and lower esophageal sphincter are relaxed. Emesis and the sensation of nausea that frequently accompanies it are generally viewed as components of a protective reflex that serves to rid the stomach and intestines of toxic substances and prevents further ingestion. Nausea is a frequent side effect of medications as well as a common feature in a number of systemic conditions, disorders of the central nervous system, and GI conditions. The most common causes of nausea and vomiting are gastroenteritis, drugs or toxins, motion sickness, and other labyrinth disorders or disturbances, and pregnancy. If vomiting is severe and a surgical condition has been excluded, an antiemetic may be beneficial in adult patients. In actively vomiting patients, parenteral agents should be used. Antihistamines are effective for the prevention of motion sickness as well as nausea and vomiting associated with migraines and vertigo, or labyrinth disturbances that are vestibular in origin. A common side effect or intended effect in some cases of antihistamines is drowsiness. For psychogenic vomiting, the athletic trainer should give the patient reassurance, showing awareness of the patient's discomfort and the desire to work toward relief of symptoms regardless of the cause. Zofran is a prototypical serotonin antagonist drug in this class that has therapeutic effects against hyperemesis of pregnancy and to a lesser degree post-operative nausea, but not against motion sickness. It is absorbed well from the GI tract and has a rapid onset of action. This drug is extensively metabolized in the liver and typically lasts 3 to 6 hours. The antiemetic effects of the drug persist long after it disappears from the circulation, and the drug can be administered effectively just once a day. This medication is available as tablets, oral solution, or an IV preparation for injection. Diarrhea. This comes from the Greek word This is typically defined as people who suffer from the too rapid evacuation of too fluid stools. Diarrhea is defined as stool weight of greater than 200 grams per day. Several basic mechanisms are responsible for most clinically significant diarrheas, including increased osmotic load, increased secretions, and decreased contact time or surface area. Severe GI conditions should be suspected in the following cases: acute watery diarrhea in otherwise healthy person. This is likely from infectious etiology, particularly when traveling, possibly from tainted food, or an outbreak with a pointed source is involved. Antibiotic-associated diarrhea, such as diarrhea induced from C. difficile, is a common adverse effect of a recent antibiotic use. Acute bloody diarrhea, with or without hemodynamic instability, in an otherwise healthy person. This suggests an enteroinvasive infection. Diverticular bleeding and ischemic colitis also manifests with acute bloody diarrhea. Recurrent bouts of bloody diarrhea in a younger person suggests inflammatory bowel disease. And diarrhea that consistently follows ingestion of certain foods, such as fats, suggests a food intolerance. Rehydration for the patient is vital. Fluids such as Pedialyte versus Gatorade. Oral electrolyte replacement is important for the patient. Oral electrolyte replacement contains water and electrolytes that link sodium absorption to glucose uptake by the enterocyte. This is followed by movement of water in the same direction. A balanced mixture of glucose and electrolytes and volume matched to those losses can therefore prevent dehydration. There are many pre-mixed commercial formulas, including Pedialyte and Gatorade. Pedialyte does not contain sucrose, which has the potential to make diarrhea worse by drawing water into the intestine, increasing the risk of dehydration. In its flavored formulations, Pedialyte uses synthetic sweeteners. Complications may result from diarrhea of any etiology. These include fluid loss with consequent dehydration and electrolyte loss, sodium, potassium, magnesium, and chloride. Diarrhea is a symptom of another disorder. When possible, the underlying disorder should be treated, but symptomatic treatment is often necessary. Pharmacotherapeutics of the diarrhea in adults should be reserved for patients with significant or persistent symptoms. Nonspecific antidiarrheal agents typically do not address the underlying pathophysiological response for the diarrhea. Many of these agents act by decreasing intestinal motility and should be avoided in acute diarrheal illnesses caused by invasive organisms. In such cases, these agents may mask the clinical picture, delay clearance of organisms, and increase the risk of systemic invasion by the infectious agent. Antidiarrheal agents are safe for adult patients with watery diarrhea. However, antidiarrheals may cause deterioration of patients with C. difficile or E. coli. Compounds containing bismuth subsilicate, also known as Pepto-Bismol, are often used to treat a variety of GI disorders, although their mechanism of action remains poorly understood. Treatment of diarrhea from an underlying GI disorder with blood in the stool is contraindicated. Anti-motility and anti-secretory agents can affect the following: intestinal motility, intestinal secretion and absorption. Anti-motility and anti-secretory agents. These treat intestinal motility, intestinal secretion and absorption. Imodium may be preferred over opioids. It achieves its plasma level 3 to 5 hours and has a half-life of 11 hours. It can be an adjunct for travelers' diarrhea. Overuse and abuse can cause constipation. Patients with inflammatory bowel disease require caution when using these medications. Patients use the term constipation not only for the decreased frequency, but also for difficulty in the initiation or the passage of firm or small volume feces, or a feeling of incomplete evacuation. Constipation is often one of several symptoms: abdominal pain, nausea, fatigue, anorexia, or an underlying problem, such as irritable bowel syndrome or depression. Constipation has many reversible or secondary causes, including a lack of dietary fiber, drugs, hormonal disturbances, neurogenic disorders, and systemic illnesses. In most patients with constipation, the chief complaint is sluggish movement of the stool through the colon. Water normally accounts for 70 to 85% of stool weight. The daily challenge for the gut is to extract water, minerals, and nutrients from the luminal contents, leaving behind a manageable pool of fluids for the proper expulsion of waste material via the process of defecation. With decreased motility and excess fluid removal, feces can become thickened and impacted, leading to constipation. If non-pharmacological measures alone are inadequate, various drugs are available for treating constipation. Medications that are the least disruptive, bulking agents, or stool softeners should be used first. More potent medications, such as stimulant laxatives, may be used, although they should be administered at the lowest effective dosage and for the shortest possible period of time to avoid dependency. Drugs for treating constipation include bulking agents, stool softeners, and stimulant laxatives. Bulking agents, also considered dietary fiber supplements, are particularly effective in treating normal transient constipation. Stool softeners work to gently lubricate the stool and draw water into the stool, making it softer and more comfortable to pass. Stimulant laxatives bind drugs and interfere with absorption. Rapid fecal transport may rush some drugs and nutrients beyond their optimal absorptive state. Contraindications to laxatives are as follows: acute abdominal pain of an unknown origin, inflammatory bowel disorders, intestinal obstruction, GI bleeding, and fecal impaction. Opioid-induced constipation. Opioids bind to the mu-opioid receptors in the GI tract, resulting in opioid-induced constipation, along with possible nausea, vomiting, or pruritus. Opioids are critical to pain management. However, after commencing opioid therapy, 40 to 90% of patients experience a reduction of spontaneous bowel movements from baseline to typical. Reduction of less than 3 bowel movements per week. This condition is associated with multiple medications used for both cancer and non-cancerous care, including acetaminophen with hydrocodone, morphine, oxycodone, acetaminophen with oxycodone, and tramadol. Opioid-induced constipation generally does not respond well with traditional laxatives, which often results in increased physician visits and reduced productivity, and prompts some patients to curtail their opioid use in order to stimulate bowel activity. Some medicines are prescribed to reverse the effects of opioid-induced constipation. These medicines should be administered 1 hour before or 2 hours after a meal. These agents are FDA approved for the treatment of opioid-induced constipation. They are not used as a first-line defense and are usually reserved for patients who have first failed other bowel regimen therapies. These medications are contraindicated for anyone with a GI tract obstruction or hepatic impairment and should be ceased if opioid use ends. Gastroesophageal reflux, also known as GER, involves incompetence of the lower esophageal sphincter that allows reflux of the gastric contents into the esophagus, causing burning pain. Prolonged reflux may lead to esophagitis, stricture, and rarely intestinal metaplasia, or cancer. Gastroesophageal reflux disease, also known as GERD, is sometimes also known as acid reflux, is more serious and longer-lasting form of GER. GERD is a long-term condition in which the stomach contents rise up into the esophagus, resulting in either symptoms or complication. Other conditions known as GERD include acid indigestion, acid reflux, acid regurgitation, heartburn, and reflux. Drugs for decreasing gastric acidity are important for treating GERD, peptic ulcers, many forms of gastritis, and in some regimens, H. pylori infections. Drugs that decrease gastric acidity include the following: antacid, proton pump inhibitors, and H2 receptor blockers. Gastritis is an inflammation of the gastric mucosa caused by any of several conditions, including infection, drugs, and autoimmune phenomena. Many cases are asymptomatic, but dyspepsia and GI bleeding sometimes occur. A peptic ulcer is an erosion of a segment of the GI mucosa that penetrates through the muscularis mucosa on the stomach or the first few centimeters of the duodenum. Peptic ulcer disease, or PUD, is considered an imbalance between the mucosal defense factor and the injurious factors. Gastritis and peptic ulcer disease can be caused by any of several conditions, including infection, drugs, stress, autoimmune phenomena, and even NSAID use. The drugs for treating H. pylori infection. H. pylori is a spiral-shaped gram-negative organism that has adapted to thrive in acid. It's commonly caused chronic infections and is usually acquired during childhood. In the United States, infection is less common in children, but incidences increase over age, with about 50% of people age 60 plus being infected. The American College of Gastroenterology Guidelines for the Management of H. pylori Infection recommend multiple therapies to eradicate the bacteria. Triple therapy is the most frequently prescribed regimen for H. pylori infection and involves drugs given for 10 to 14 days. This includes a proton pump inhibitor, amoxicillin, and clarithromycin. Gastroenteritis is an inflammation of the lining of the stomach and small and large intestines. In most cases, are foodborne, waterborne, or spread via person-to-person infection, although gastroenteritis may occur after ingestion of drugs and chemical toxins. In the United States, an estimated 1 in 6 people contracts foodborne illnesses every year. Gastroenteritis is usually uncomfortable, but is self-limiting. Viruses are the most common cause of gastroenteritis in the United States. Treatment typically includes bed rest, rehydration, and the avoiding of fruits. The norovirus is generally found among groups of people who have maintained close contact and eat from a common dining hall. A college basketball team is the perfect breeding ground for norovirus. For example, the case of a team that was infected with norovirus during their postseason tournament. In this case, all members of the team's travel party ate the same food in the same dining area. Players were housed 2 per hotel room, and everyone took the same bus to and from games and practice. The initial patient, a player, presented with vomiting and nausea from an unknown cause. Initially, these symptoms did not raise concern from the team's medical staff. The patient was considered an isolated incident. He was treated with over-the-counter medications to relieve diarrhea symptoms. Soon thereafter, patient 2, another player, and patient 3, a coach, also presented with the same symptoms. Within a matter of hours, other players and staff members complained of gastric distress, fatigue and weakness, and loss of appetite. The same patients also presented with a low-grade fever, but none spiked a fever over 102 degrees, as would be associated with food poisoning. For each case, symptoms come on fast and generally resolve within 72 hours. Conversely, other members of the travel party followed the same meal and travel routine as those who became ill but were not affected. Norovirus is challenging to athletic trainers and other healthcare providers for many reasons. One reason is that the pathogen is a virus and thus cannot be treated with antibiotics. Also, antivirals are generally unsuccessful in treating this infection. The reflexive thought is to rely on over-the-counter antidiarrheal medications, but in the case of norovirus, the medication could delay excretion of the virus. The best course of action is to isolate the affected people away from the group and emphasize frequent hand washing by everyone. Affected people should do their best to maintain hydration, rest, and monitor themselves for more significant medical conditions such as bloody stools. Functional bowel disorders are a spectrum of chronic GI disorders characterized by predominant symptoms and signs of abdominal pain, bloating, distension, or bowel habit abnormalities. A common functional bowel disorder is inflammatory bowel disease, IBD, which includes Crohn's disease, ulcerative colitis, and irritable bowel syndrome. It is characterized by relapsing and remitting condition with chronic inflammation at various sites in the GI tract. This results in diarrhea and abdominal pain. Inflammation results in a cell-mediated immune response in the GI mucosa. NSAIDs may exacerbate IBD, inflammatory bowel disease. Patients should follow diet restrictions, avoid lactose or gluten, and treat bowel symptoms using a previously described agents. In summary, nausea and vomiting have multiple etiologies. Most conditions are reversible, and many of them have multiple non-prescription treatments. More chronic conditions may damage tissues, and athletic trainers should be responsible for providing supportive care and advice for our athletic populations.